Very good morning, everyone, and thank you very much for that detailed and generous introduction. And I'm really humbled and very privileged to be here talking to you. And when I was asked to make a talk about a topic in KSM, what I thought was I should talk about leptospirosis because it is one of the very common diseases. And as people who are working in medical wards, we see there are a lot of patients being admitted who are coming with very bizarre and atypical presentations. And also at the same time, the course of the leptospirosis is now much complicated, and unfortunately we do see a lot of patients who succumb to disease as well. So because of that reason, I thought this is one of the important topics to talk to this sort of an audience. So I'm not going to talk much about microbiology and pathophysiology. Rather, I will focus on a clinical case, an authentic case which we have recently managed in Peradeniya, and take the discussion from there. But just to talk about leptospirosis, as you all know, it's a bacterial infection, and it is recognized as one of the, as the most widespread zoonosis in the world. And it has become an emerging health problem worldwide because it is largely been underreported, misdiagnosed, and also it's a great masquerade. It mimics a lot of other diseases. So then with this map, you will understand the gravity of this problem. So you can see the tiny island in the Indian Ocean, but it is being colored very dark, and it is one of the countries which is having the highest prevalence and incidence of leptospirosis. So we in Sri Lanka, I think it's very important that we know about this condition. Right, so from the Sri Lankan context, it is one of the common causes for febrile illnesses in the local context, and particularly we talk about a lot of dengue and dengue deaths, and there are dengue death reviews, but if you take the statistics, the annual deaths due to leptospirosis for the last couple of years is more than dengue. So that is very important. And then the other important thing is there is a paradigm shift. Now those days, even when we were students, when we talk about leptospirosis, we talk about a poor farmer coming from a rural village and has come in with this arthralgia, myalgia and fever, and then jaundice, and then diagnosed to have leptospirosis. But now the shift is such that a young boy coming from Colombo 7 who has never stepped into a paddy field with fever, still you need to suspect the possibility of leptospirosis, which I will explain in my subsequent slides. So the epidemiology has changed from rural to urban, and adults to children, and from poor to rich. At the same time, it's not only the epidemiology, the clinical presentation. So now we do see various severe forms of leptospirosis. Predominantly there is pulmonary involvement, cardiac involvement, and the renal involvement. So this is the case that I am going to talk to you. So he's Mr. Ajit. He's a 58-year-old farmer who is coming to teaching hospital Peradeniya with this classic history: high-grade fever for 3 days with chills, backache, myalgia, and headache. And then in background, he's apparently well with no significant past medical history. So he's a fit and well farmer who's coming with this sort of a short febrile illness. So this is from my house officer's notes. So he has done a thorough examination and found that patient is unwell, dehydrated. There is conjunctival injection, mild icterus, pulse rate is around 100 per minute, blood pressure is 90/60, tachypneic, lungs has vesicular breathing, and mild right hypochondriac tenderness. So at the outset, what are your differential diagnoses? Now looking at, knowing the topic, you think leptospirosis is up in the list. Yes, it is. But other than that, when this sort of a patient comes, we suspect a lot of other possibilities, right? So yes, leptospirosis could be dengue, could be rickettsial infections, being in the hill capital of the country. And sometimes atypical pneumonia can present in this way, and it may be a surgical cause as well, like biliary sepsis or sometimes hepatitis. So there is a very broad differential diagnosis in this patient. And then, so out of his symptoms, right? So I have not included this research here, but out of these clinical symptoms, what do you think will favor the likelihood of leptospirosis? Now I have given 8 options: high-grade fever, headache, arthralgia, severe myalgia in calves, backache, nausea, vomiting, diarrhea, and red eyes. So this was a simple study done some time back where we wanted to find which of these following symptoms would predict the probability of having leptospirosis over the other febrile illnesses. So these were the statistically significant symptoms. So those who complain of severe myalgia in calves had a high likelihood of having leptospirosis in contrast to arthralgia. and also backache, lower backache, and red eyes. They had very significant associations with possibility of leptospirosis. And similarly, with regard to clinical signs, conjunctival injection, muscle tenderness, icterus, lung crackers, right hypochondriac tenderness, and rash. Right, so I will just go through this rather than asking the questions. So these two signs, patients who have severe muscle tenderness, those who scream when you press on their muscles, and those who have conjunctival injection, these two physical signs favored the possibility of leptospirosis over the other febrile illnesses. Right, so moving to the case definition, this is what your guideline will tell. What is a suspected case of leptospirosis? Well, basically covers most of the febrile illnesses, because when we see patients with fever, they have headache, they have muscle pain, they have prostration, jaundice, conjunctival suffusion, all these symptoms. So the suspected definition needs only one of the following, right? Maybe a patient with fever and headache who is coming with a history of exposure and or evidence of organ involvement, right? So this, of course, we can't use much in our clinical practice, because then we will have to consider leptospirosis in almost all the patients who are coming with fever. So here the history of exposure is very important, right? So we generally consider the high risk occupations such as paddy farming, construction work, gem mining, sand mining, and also in our context those who are working in Hirakotu, Kohilakotu, etc. because they have a lot of exposure to this pathogen. And again, the recreational activity. So that is why I mentioned that young boy from Colombo 7 coming with fever, still you need to consider the possibility of leptospirosis, because there are a lot of recreational activities now. Now after COVID, now people are traveling, and there are a lot of places in Sri Lanka which will offer a lot of sort of eccentric exposures to people, like say whitewater rafting, and then exposure to jungles and exposure to other various activities. And then the contact and contact with the contaminated water, right? So starting from the drains, wells, and bathing and washing in small water streams, rivers, lakes, and the flood water. And also contact with the animals or animal tissues like cattle and buffalo. So all these things are high risk exposure. So it is very important that you have to get a detailed history from the patient with regard to what their exposure is. Right, and then this is again important whenever you suspect leptospirosis. You don't have to wait for your IgM to be positive or MAC to be positive. You have to notify the leptospirosis, because again the epidemiology unit is facing, because we don't see the real numbers now. Most of the lepto patients are being managed but not being reported. So that is again a big problem. So as house officers and as doctors who are working in the ward, the notification is very important. Right, and then the other thing is, although we call leptospirosis as a disease, now it is considered as a syndrome, because leptospirosis can affect almost all the systems in the body. So you name the system, leptospirosis can complicate it. So from the cardiac, respiratory, gastrointestinal, renal, liver, hematological, neurological, so all sort of complications are there. And actually this is a bit of a crowded slide, but you can see the spectrum of leptospirosis, starting from myocarditis to all sort of cardiac arrhythmias, from pulmonary hemorrhages, pulmonary edema to ARDS, and if you take neurological, from meningoencephalitis, transverse myelitis, even hemiplegia and Guillain-Barré syndrome, all sort of complicated manifestations are there. So that is why at the outset also I mentioned leptospirosis patients may not have the classic presentation, but they may present with one of these syndromic symptoms and signs. So always you should have a lower threshold in suspecting leptospirosis. Right, so this again I will skip, and I will just go through the patient's investigation. So these are the basic investigations that we have done to our patient, Mr. Ajit, right? So his full blood count, the WBC count is 15 with the neutrophil predominant count. His hemoglobin is 13.5, it's normal, and he has low platelets. I mean, this is very obvious, you know, the typical presentation in a full blood count. You see neutrophil leukocytosis and the thrombocytopenia. And importantly, the leukocytosis may not be there, but most of the time you see neutrophilia, like it may be like 8 of WBC, but maybe 90% neutrophils. And this is his renal profile. The creatinine is 1.26, say baseline is 0.7, so there is an AKI, and the potassium is 2.9. So this is again an important observation because in leptospirosis you do get acute kidney injury, but hyperkalemia is not very common in the initial part, because leptospirosis mainly it causes an interstitial nephritis and they lose potassium. So most of the time in patients we see high creatinine level along with hypokalemia. This is important because sometimes when patients come and they are at a stage where they need renal replacement therapy in the form of a dialysis or something like that. So in that case, we have to be very cautious about potassium, because we have seen a lot of patients having fatal cardiac arrhythmias in the dialysis room because of low potassium if it is not being corrected. So potassium is something that you must check before thinking of some sort of a renal replacement. It needs correction. And then looking at the liver profile, yes, there will be a transaminitis, and then ALP is high, and you can have high bilirubin level where the direct fraction is more than the indirect fraction. So there will be direct hyperbilirubinemia and a transaminitis. And this is again an interesting observation. A lot of medical students are here. So microscopic hematuria is something that we commonly see in patients with leptospirosis. Right. So now we have got the history, you have got the examination, and you got the investigations findings as well. So most probable diagnosis in this patient is leptospirosis, which is complicated with mild AKI and a mild transaminitis. So that is the beginning. That is the time the patient got admitted to the ward. Right. So how do you confirm leptospirosis in this patient? Right. So do we usually confirm? Because it's a clinical diagnosis and management is straightforward, and the other important thing is when there is a delay in managing leptospirosis, the complications get more and more severe. So we don't wait for any sort of confirmation as such. On clinical grounds, we do treat patients. But these are the diagnostic tests that we have to diagnose leptospirosis. So a positive culture in pathogenic leptospira, I will discuss little in detail in the next slide. Positive PCR for leptospira and the MET. So isolating this organism from molecular methods or from cultures or microscopy, they are considered as direct methods, but they are not that sensitive, they are difficult, and they are not done in most of the centers in the country. Particularly isolation of leptospira, it's a very highly infectious organism. So when we talk about this microbial isolation, we talk about biosafety levels. You need at least facilities of biosafety level 3 to culture this organism. So because of that, they are done in very limited number of units in the country. So it is again not practical when it comes to clinical management. PCR can be done. It can diagnose the disease early, and but again that is again time consuming and labor consuming and it's expensive, so not routinely done. And when it comes to dark ground microscopy, it is a possible test, but the sensitivity and the specificity is very low. Right? It is very difficult to isolate leptospira, unlike the other things like syphilis, to isolate in dark ground microscopy. And antigen detection method is having a very low sensitivity. So at the moment also there is a study that we are doing in Peradeniya where we are testing one antigen kit with the gold standard, and we did not have a single positive test from the antigen kit compared to the gold standard. So they are again available in private sector also, but having a private sector antigen test negative does not mean that patient doesn't have leptospirosis. So this is probably the take home message, particularly when we ask leptospirosis tests in private sector. They use all these antigen tests, but they are not being validated for us, and the real yield from those antigen tests are very poor. And then the MAT test. So this is the serological reference method. This is what we consider as the gold standard. But the thing is, MAT antibodies are usually positive after day 7, right? So by that time, if you have not treated the patient, he will be having all sort of complications that we have discussed. And the other thing is, this is not very applicable in our context, but certain infections like syphilis, retroviral infections, Lyme disease, certain autoimmune diseases can have cross reaction, so MAT can be positive, right? So what is generally recommended for us is a MAT titer more than 1/320, or else we need to show a fourfold rise in from acute to convalescent serum. And then ELISA tests are again being used in most of the laboratories as a rapid diagnostic assay, and this is again having fairly good specificity and sensitivity. Right. So we'll now briefly discuss about the management of this patient. So when you have a leptospirosis patient on clinical suspicion, one important decision is that we need to decide whether we are going to manage this patient as an inpatient or an outpatient, right? So I will briefly talk about outpatient management. So this outpatient management is reserved for patients, suspected patients with leptospirosis with no organ involvement, without significant comorbidities, and even in the guideline this could be is involved because I mean, you need a very close monitoring of these patients. At the outset, they may be asymptomatic, they're just having fever and blood investigation suggestive of lepto, but maybe on day 2, day 3, they might get complicated. So, particularly patient who can be easily followed up, a reliable patient with no organ involvement and not having any complicated diabetes, hypertension, like other comorbidities, yes, you can opt to manage as an outpatient, and the treatment is doxycycline. That is 100 milligram 12 hourly for 7 days. But patient should be given very clear instructions to monitor the urine output, and we have to do safety netting for these patients, like if they develop jaundice, if there is a reduction in urine output, any cough, hemoptysis, breathing difficulty. So all these things, if they develop any of these symptoms, they need to come immediately to the hospital. Otherwise, still if we are managing as outpatient, we need to see them in every 48 hours. So after first 48 hours, you do the basic investigations again, and then you assess the patient, and if they remain asymptomatic, you can reassess them in another 48 hours. Right. So when it comes to inpatient management, so most of our patients, as you know, will not qualify for outpatient management. So right, in the patient, they may be having very low platelet, they may be having very symptomatic, dehydrated, maybe having mild AKI on admission, so they need admission. So inpatient management, the fluid management is important. Particularly, we have to assess the level of hydration, because usually at the prodrome they have not been eating and drinking well, so they may be dehydrated. So initial renal impairment may be not the interstitial nephritis, it may be dehydration. So you need to push some fluids in, and then you have to monitor the input output. And also the replacement of potassium is something that you need to be very cautious, right? So you need to check their potassium and replace accordingly. And for fevers, again, yes, just like dengue, paracetamol, but you need to avoid NSAIDs. And then with regard to the management, the antibiotics, right? So we have 3 options. One thing is the standard penicillin that we give, 1.5 mega units 6 hourly. We can go for ceftriaxone 1 gram 12 hourly, or cefotaxime 1 gram 6 hourly, right? So coming from like discussing the evidence, now what is shown the best is the cefotaxime 1 gram 6 hourly. But the recent most guideline, which was revised very recently, they put the ceftriaxone in the first place, the reason being the ease of administration. So it is twice a day, because otherwise cefotaxime we have to give every 6 hourly. So ceftriaxone is put as number 1, but then cefotaxime and penicillin can be considered. Particularly patients who have severe thrombocytopenia and renal impairment, the ceftriaxone is the preferred one according to the current guideline. And then this is again very important, that something that we don't do, which is an important principle in antimicrobial stewardship as well, that de-escalating the IV antibiotics to oral amoxicillin once the patient improves. Right? Sometimes in the ward we find that patients are started on cefotaxime or ceftriaxone, and they are on and IV antibiotics for day 7, and on the time of discharge we discharge them home. It should not be the practice. So if the patient is able to eat and drink, and if the renal functions are back to normal, if the patient is clinically stable or fever, certainly we can omit the IV antibiotics and put them on oral amoxicillin. Right? It can be done even while in the ward as well. And the total duration of the antibiotic therapy is 7 days. Right. So there are special situations where the patients who have hypersensitivity to penicillin or cephalosporins, then we can use doxycycline, and certain instances we might have to go for meropenem, particularly in very unwell patients needing ICU care, where they have severe penicillin allergy or severe cephalosporin allergy. We can consider using a carbapenem instead, and or else we can go for doxycycline. And the patients who are in pregnancy, breastfeeding, and children under the age of 12 years, doxy is not recommended. So in such categories, we can use either penicillin, or as outpatient, as oral therapy, azithromycin or clarithromycin. Right? Okay. So then again another small question, what are the factors associated with severe disease? I mean, knowing these factors are important, because then we can predict the outcome, or we can predict what will happen to the patient, or we can prognosticate him. So old age, chronic alcohol abuse, raised transaminases, leukocytosis, low packed cell volume and hyponatremia. This is again coming from that previous study. So we looked at the factors that are associated with severe disease. So out of that, these were the significant ones. So those who take chronically alcohol, and those who had elevated liver enzymes at the time of admission, and those who had high white count compared to a normal white count with neutrophilia and hyponatremia on admission, predicted a severe outcome in most of these patients. Right, so we will go to talk about our patient once again. So now patient is being admitted and he is receiving antibiotics, and on day 3 of the admission the patient is noted to be more dyspneic and he was having a new oxygen requirement and complaining of a cough. Right, so on examination he was found to be tachycardic and he's on 6 liters of oxygen, maintaining saturation at 94%, and the heart rate is 120 and blood pressure is marginal, and he was having bibasal crackers. Right, so in this patient we have again repeated the whole set of investigations to see there are a lot of very alarming investigations. Right, so creatinine has gone up to 4.5, and initially he was hypokalemic, but now the potassium is 6.5. There is severe thrombocytopenia, significant transaminitis, and patient was of course deeply icteric with a bilirubin of 180. And in the chest X-ray, I am not sure whether it's very clear, but it has started to develop certain patchy areas in various places in the chest X-ray. And again, the initial ECG was normal, but now it was showing widespread T inversions. So very complicated case, and he is having the typical leptospirosis syndrome. All the organs are getting involved. Right, so he has an AKI with hyperkalemia, severe thrombocytopenia, worsening transaminitis with cholestasis, possible pulmonary hemorrhages, and possible myocarditis. Right. So from now onwards, I will briefly touch upon these individual complications and just discuss the principles of management. Right. So talking about renal involvement, it is again something very important that you need to suspect from the time of admission. So always ask about the patient whether he has a good urine output, look at the input-output chart and see whether he has got hematuria. Right. So by definition, this is the standard definition of AKI which we apply for the lepto as well. And in urine sediment, we might see hematuria, granular casts, red cell casts as well. So if the patient develops renal involvement, the practice essentials, of course you need to monitor the urine output. Patient needs daily serum electrolyte and creatinine, and always you need to detect and treat the hypovolemia. Right? Sometimes we attribute it to the interstitial nephritis. Okay, this is leptospirosis, to see patient is very much dehydrated. And then the indication for dialysis is more or less the same as for other AKIs, but the most important thing is you need to correct the potassium during the dialysis. And then this is again coming from one of the other studies from some it's not a local one. The daily short intermittent hemodialysis are shown to be beneficial over alternative hemodialysis over peritoneal dialysis. So rather than giving the standard hemodialysis for 4 to 4.5 hours, if we can provide, if the facilities are available, daily short hemodialysis, that will improve the prognosis. And the bicarbonate based diacylate compared to acetate, and always treating the hypokalemia. And importantly, the hyperkalemia with renal impairment in lepto sort of predicts a poor prognosis, and you need to give the standard treatment for hyperkalemia. And then coming to the liver involvement, yes, presence of jaundice, tender hepatomegaly, significant transaminitis and rise in bilirubin, alkaline phosphatase and gamma GT will tell that there is liver involvement. And then most of the time, the good thing about liver involvement is, unlike the kidneys, the recovery is most of the time complete and there are no long-term sequelae as such. And when the patient has fulminant liver failure, very high transaminases, yes, there are basically evidence coming from case reports and case series that N-acetylcysteine can be useful, as in other cases of acute liver failure, but there are no good quality evidence coming from randomized trials to support the use of NAC in leptospirosis. But this is something that we widely practice. And then coming to the cardiac involvement, yes, symptoms, shortness of breath, chest pain, palpitations, very non-specific symptoms, very non-specific signs. And ECG, of course, you can see arrhythmias, ST changes, T wave changes, as in all the other causes of myocarditis and pericarditis. So here the problem is the chest X-ray can be misleading because abnormal chest X-ray in a leptospirosis patient could be due to heart failure due to myocarditis, could be due to pneumonitis, could be due to respiratory distress syndrome or fluid overload. So you have to interpret a chest X-ray if you do with caution to see what really has happened in this patient's chest. And again, doing troponins are not very useful because it can be elevated even due to other causes in leptospirosis. And the current management of cardiac involvement is basically supportive therapy with correction of deranged hemodynamic parameters. This is, I think, the most important involvement in leptospirosis, which is the killer in leptospirosis, the pulmonary involvement. Right? Sometimes the symptoms and signs can be very subtle, but if you pick it up and do a chest X-ray, you can see very florid changes in the X-ray. So always monitor their saturation and ask about the symptoms of cough, breathlessness and hemoptysis, and always take some time to see what their respiratory rate is. Maybe the tachypnea may be the only sign that will tell us that there is ongoing lung involvement in a patient with leptospirosis. Right, so again the practice points, the steroids is what we use very commonly when there is lung involvement, but I will talk about that research. But it is indicated mainly in early lung involvement. So that is why it is very important to pick up the possibility of a lung involvement, right? So within 12 hours of respiratory symptoms, if you have given steroid, that is shown to be very effective compared to giving steroid when the patient has full-blown pulmonary hemorrhages and intubated in an ICU. And the steroid is methylprednisolone 1 gram intravenously for 3 days, followed by oral prednisolone 1 milligram per kg per day for total of 7 days. Again, also, although I have stated this as a fact, the level of evidence is very low. This is based on some descriptive studies, and there are no randomized sort of case control, randomized trials which sort of tested the use of methylprednisolone against not giving methylprednisolone. And at the moment, I think it will be difficult as well, because we sort of recognize this as a standard therapy. So when a patient is very unwell with whiteout lungs, we might not withhold methylprednisolone for a research purpose. So it is something difficult to do now. And then the mechanical ventilation is indicated in patients with severe lung involvement. And then basically we need to go for a lung protective ventilation with low tidal volumes. Right, so hematological involvement, again, yes, you can have coagulation abnormalities, thrombocytopenias, and some patients can go into DIC. Right, so we'll talk about our patient. Right, so this man, Mr. Ajit, had multi-organ involvement. So his heart was involved, the kidneys were involved, liver was involved. So then we did consider the place for steroids in this man, and actually there's one study coming from Peradeniya some time back, where they have done a descriptive study of using high efficacy bolus methylprednisolone in severe leptospirosis. So this is what they have tested, and this is what is there in the current guideline as well. But the most important thing is it should not be given too early and should not be given too late. So this is again from the same paper, that this is the clinical score that they sort of developed to categorize the patient's severity, right? So if you get a leptospirosis patient in general stable condition, no complications, yes, 0. But depending on the organ involvement, we were adding 1 by 1. Right? So if the score is like 7 or 6 or 7, then it is very high score, and giving methylprednisolone did not change the mortality. Giving methylprednisolone to a patient who has a score of 0 or 1 again worsened the outcome. But in the middle category, they showed some benefit with the steroid. So that is why too early or too late, an intubated patient with completely wiped out lungs who are having ET bleeding and who is on hemodialysis with 3 inotropes, giving methylprednisolone will not change the outcome. Right? So you need to pick up the lung involvement predominantly early in the course and consider methylprednisolone. Right, so what we have done for this patient is he needed high flow oxygen and then subsequent intubation, and he needed a high FiO2 and a peak to maintain saturation, and then he developed ET bleeding, and chest X-ray was worsening, and the oxygen requirement was going up, and we were doing platelet transfusions to keep the platelet count more than 50. And of course his case, his methylprednisolone was started in the ward on day 3 of admission, and it was continued for 3 days, but his condition somewhat deteriorated, needing the ITU input. Right, and then we considered this option for our patient, the place for plasma exchange. Right, so the guideline talks about possible better survival rate among patients who received plasma exchange in addition to the standard therapy. But of course, in practice, I think you all will agree here from the medical wards that we do offer plasma exchange for patients who have severe disease with pulmonary hemorrhages, and we have seen very good outcome in these patients. So what is recommended is to have 3 to 5 cycles in consecutive days, and giving IVIG with plasma exchange has shown no additional benefit. So plasma exchange is something that we need to consider, although the level of evidence is low, because there is a possibility that the survival could be better with the plasma exchange with the rest of the management. And then talking about the ECMO, right? So the role of extracorporeal membrane oxygenation. We have a few places in the country, and there are few patients who recovered well, are reported from Goal, and this is a nice review article again from a team of Faculty of Medicine in Ruhuna, done and discussed the use of plasma exchange and ECMO in treatment for pulmonary hemorrhages in leptospirosis patients. Right, so talking about the outcome of our patient was treated with IV cefotaxime and doxycycline. Again, this is, yes, doxy is something that is not recommended to be given in combination with penicillin or cefotaxime, because doxy is for outpatient management, could be used in discharge, but there is no lot of rationale in giving cephalosporin plus doxycycline. But in clinical setting, we do use doxycycline in certain patients, probably because some patients have bit of thrombocytopenia, aches, pains, and they may be coming from, say, Pilimathalava, Kadugana. We might think there could be an overlap, could be leptospirosis or rickettsial infection. So in that context, we sometimes consider using these two antibiotics together, but if it's a confirmed very obvious case of leptospirosis, adding doxycycline will not give additional benefit to the patient, particularly in inward patients. So he got methylprednisolone and prednisolone and IV noradrenaline to maintain the blood pressure, and he was on CRRT as a renal replacement therapy. He had 3 cycles of plasma exchange, and then he was discharged on day 4 of admission. So it's not a sad story, it's a success story, where we had to use almost all the I would not say standard, but almost all the recognized treatment strategies to manage a patient with severe leptospirosis. Right, so then I will briefly talk about the prophylaxis. Yes, it is something that is well recognized in high risk groups, and this is not advocated as a routine or a leading preventive measure, right? So say for instance you have bad wounds in your legs and you go on a picnic and then you decide to jump into an abandoned river. So you can't be sort of staying reassured, okay, I have taken doxycycline so I can get exposed. No, this is not a leading preventive measure, but something that we can use as prophylaxis. The dose is 200 milligrams once a week, and this is usually recommended to be started a few days, at least a week, within a week, a few days before the exposure. Again, this prophylaxis cannot be used in age less than 12 years, pregnancy, lactating mothers, and presence of previous allergy for tetracyclines. So there is an interesting study where it was done some time back, not published though, I think Professor Sam Kularatna. So he did a trial where they used penicillin as the prophylaxis to see what's happening with leptospirosis. So this was started, but then as just like other epidemics, they peaks and they go down. So by the time it was started, the number of leptospirosis patients were less, and then it was not done. But according to the available data, it is again something that we can consider using in patients as prophylaxis, those who are contraindicated to have doxycycline, but it is not there's no published data or clear evidence for that. Right, so that brings to the end of my short presentation. So I just wanted to discuss about the current presentations of leptospirosis and what whatever the available management strategies. So just like Saman sir promoted the membership of KSM, so as the last slide, I will take another 2 minutes to introduce the Center for Research in Tropical Medicine. So because I'm the coordinator of the CRTM and we have been doing a lot of activities recently. So it's just an open invitation for those who are interested to join hands with us, because there are a lot of research going on and we are looking for collaboration. So this is a textbook of tropical medicine published from the CRTM, edited by Professor Kalana, Professor Siji and Professor Pulratna, and this is available, you can purchase, and this will give a very good outline about all the common tropical infections. And then we have done a workshop on tropical medicine. I think we concluded the first workshop last week, a 3-day workshop which was open for all postgraduates. We had around 50 postgraduates enrolled, a 3-day workshop which we covered all the common tropical medicine topics. And a monthly CME lecture is done from the CRTM, and there are elective programs for the international students. And in the coming October, we are getting the professor of ID from the University of Connecticut and planning on ID symposium aiming mainly the postgraduates. And we are working on a newsletter which will be out soon, and a CRTM picture book. Again, this is an open invitation because being in Kandy, like seeing a lot of patients, you see a lot of tropical infections and you see they have a lot of skin manifestations, various other manifestations. So the photos. So what we are planning is we will give the courtesy to those who submit the photograph, and we'll have a brief discussion and a picture book on tropical diseases. Right. So that's about CRTM. So that brings to the end of my presentation, and I'm happy to accept any questions if you have on the topic.